Hi everyone, we're doing Module 4, Chapter 4 in your book, Using Good Body Mechanics. Okay, need to know words. We're going to go through these as we go through the PowerPoint. However, some ones that I want to emphasize so you're highlighted to that is the words contracture, and that's when the arm or leg, the ligaments pull up and they bend the person's joint and they can't straighten it again. Pressure ulcer is very important in healthcare. That's when you get bed sores or openings in your skin from just sitting or laying too long in one place. And so those two are really important. And they're all important, but they may be new words for you. Okay, so again, good body mechanics objectives. Is that I see you do good body mechanics and using lifting techniques, and also with explain the procedures of how to ambulate or walk someone, position someone, identify proper positioning, demonstrate how to move the resident, I know this is cut off, resident and bed, and how to transfer a resident. Okay, a lot about moving patients in healthcare is a safety issue for the healthcare worker, number one, and the patient, number two. So I'm going to go through some guidelines, but always evaluate the situation. If you don't think you can move that 300-pound person yourself, get help. Prepare the area for the move. Sounds real simple, but if the patient can move himself a little bit, we've got to get everything out of the way so we don't trip and they don't trip, and we have enough room to move wheelchairs back and forward. And again, for body mechanics, so we don't hurt ourselves, lift only when necessary. You're going to push, pull, or roll whenever you can. And a main item is to keep your back straight and use your other muscles, your arm muscles, your thigh muscles. Okay. Others, remember, position your feet apart, one slightly ahead of the other, like we said, okay, shoulder length apart. Stand close to the object that you're lifting. So that's really important. And even when you're working with patients in the bed, if I could get a few inches closer, get closer. It makes all the difference. Do not twist. So we're not going to twist like this. Do not bend at the waist. Okay. Bend your knees and lift with your leg muscles. So that means that you're going to go down in a squat to do things. Okay. Okay. Know that lifting and moving patients is a major cause of injury to healthcare workers and patients. Good body mechanics helps to protect you and the resident from injury, but it's not going to do everything. You've got to check the situation. If you can't do it on your own, you can't do it. But there is equipment and other people to help you. Otherwise, it's safer to stay wherever they are. Check the care plan before you move anyone, and we've had that happen in clinical where students feel comfortable moving people at some point, and then they move patients that aren't supposed to be moved. So, and consider your safety first as well as the patient's safety. Okay, so here we're ambulating patients, and patients, why do we ambulate or walk them? Ambulate means just to walk. Well, it increases circulation. It exercises muscles and joints, aids in digestion, and maintains bowel function, meaning that they don't get as constipated. Always check the care plan for what level of assistance is needed. So some people they just need supervision. Other people need partial assist. Other people need total assist. Don't just encourage, but put on non-slip footwear. I should have changed that. Be alert to any sudden loss of balance. So even though you're walking along, maybe talking with them, keep looking at the patient, because what we don't want to do is if a patient is going to go down, we don't want them to fall down. So what we would like them to do, and excuse me, let's see, this is my patient. We're walking with them. We see they're unsteady. We're going to get close to them or get them close to us and try to ease them down to the floor, right? It's okay if they go down on the floor as long as they don't, hurt themselves and hit their head. And then if that ever happens, stay with that person. Don't move them. Generally, if their head is on concrete or a hard floor, we may see if there's a blanket or something we could put under, but not really lifting their head, just kind of sliding it under there. But stay with them until they're approved to move by a nurse or a supervisor. Okay, positioning a patient. Positioning just means placing the body in a good sitting or lying position. And again, you think, oh, what does that mean? So you're going to position them. But if people can't move themselves, we need to move them. It promotes good circulation within your blood vessels. It increases comfort and well-being. Prevents deformities and contractures, right? Your hands contracted, your arms contracted. And it prevents loss of muscle tone. I mean, just move, even when we're moving them, helps their muscle tone. And it prevents swelling in some cases if they tend to get swollen, and edema is just another word for swelling. And it prevents pressure ulcers. That is probably the most important, and those are bed sores or just openings in the skin where they've been lying too long. Okay, so always check the plan of care. And refer to those lifting guidelines we said. And this is a key one down here, so I should have emphasized it a little bit, but repositioning should take place every 1 to 2 hours. So 2 hours is the key. That comes up again and again on different test questions. How often do you have to reposition everyone? Studies have shown that people are moved every 2 hours. It keeps them healthier and prevents pressure ulcers. So I think I'm going to skip along and I'm going to show you pressure ulcers and then I'll go back. Okay, so how does a pressure ulcer is when there's pressure between the bed and the person, or the wheelchair or the chair and the person. And at first your skin just starts to get red. Okay, so here's one on the hip, here's one on the hip. But the difference with that is if the redness doesn't go away after 5 to 10 minutes, then it's a pressure ulcer. Okay, so these are stage 1. They stage it 1, 2, 3, and 4, and there's irregularities in the skin, such as pale, pinkish red skin, or if they're a dark-skinned person, it might be even darker, looking like a bruise, but it could also be grayish. So it depends kind of where they're at in the process of pressure. Slow or no return of color when attempting to blanch, so when you press it down like this. Okay, and then let's look at this. So how does a person go from stage 1 to stage 4, right? That is right underneath the skin. It's hitting the muscle. You see some adipose tissue there. You could tell it's not really attached. They call that tunneling. So we're going to do that more in chapter 7, but I want you to know what we're trying to prevent. I think a picture speaks 1,000 words. So these pressure ulcers are also called decubitus ulcers or bed sores. They're serious skin problems related to inactivity. They're painful, and the treatment is difficult. Once they're open and they're hard to heal, and complications can even cause death. I mean, they can get infected and cause a huge infection, which causes the rest of the body to not do well because you treat it with antibiotics, and then the kidneys shot down, and it's one thing after the other. Okay, so what's prevention? Frequent repositioning. And what did I say? Test questions usually say at least every 2 hours. Careful observation. And skin care. Keep the skin clean and dry, especially in the buttocks area if they're incontinent. And lubricate it, right? So I say lubricate it, some kind of lotion. And no, there are other specialty beds that don't have as much pressure, and then there's different pressure relieving pads and cushions and wedges. So those things are much less expensive, I hate to say money, then treating a pressure ulcer, not to mention the pain that the patient goes through. Okay, so now here's a few, just so you understand different positions. Okay, we've already done the lateral position, or laying on the side with the pillow under the head, under the arm, between the legs, and there's one behind the back. When someone is supposed to be positioned supine, they're just on their back, or I remember they're on their spine. And so the first thing is to support the feet with a footboard or pillow. It's usually a pillow. And so the pillow goes under the foot. If this teddy was a pillow, it would be under my foot, okay? So that way, my heel is not resting on the bed, and it's called floating the heels, and I don't have a good picture right here about it. And you can have other pillows, but the biggest one is under the head and underneath the ankle area, going up to the calf, so the heels don't touch the bed. Okay, there's different words for different bed positioning. So this one is called a Fowler's bed. Fowler's position, it's 45 to 60 degrees. However, those are kind of old school terms, and meaning that, we don't use them as much as saying the doctor will write an order, or physical therapy, they'll say, raise the head of the bed 45 to 60 degrees, okay, or have the bed at 30 degrees with the knees slightly bent. So you could, beds will also go up like this. Does everybody have a hospital bed? No, but they use them a lot in the homes. Okay. Oh, and then it says align. The word align. We always want to have our nose over our navel. So that keeps the back in good alignment, and then your arms are positioned on either side and legs. Okay, chair positioning. So we're going to get people in chairs, and yes, there's a certain position, but once you lower the person in the chair, you want their hips against the back of the chair, right? So I'm going to show you my chair. If I was like this, my back is not against the chair. You want the person to be up against that back of that chair. Okay, feet flat on the floor, and if the person can't move, and we move them into the chair and they literally can't move, we have to check the client frequently for comfort and proper positioning. In fact, in CNA we teach, because it's a law, that we have to actually do at least a walk by every 15 minutes. If that client is completely immobile and they're kind of restrained. Okay, so, and it depends on the situation, but if they have something in front of them, sometimes we put a little desk in front of them. If they can't move, but they could lean over, that's called a restraint. So we have to check them, even just a walk by every 15 minutes, make sure they're comfortable. Okay. And I just talked about restraint. So and it's not to restrain or tie someone down. An example would be a seatbelt. So that's kind of restraining someone. If they're in a wheelchair, that is a restraint. But a lot of times we actually put trays. It's kind of like if a high chair has a tray attached, there's these attachments you can put on wheelchairs and special chairs. So the person has a tray in front of them, and they can actually lean on it or put things on it. But if they can't get it off, it's considered a restraint, and it requires a doctor's order. Okay, so I'm going to go afterwards. I'm going to go through your book real quick just to show you pictures. But if we're turning a resident away from us, make sure if they're on a hospital bed that the side rail on that side is up and they can reach for it. However, if not, make sure that we're not too close to the edge of the bed, that if the person turns on their side, they're not almost falling off. Just some quick reminders. If we're helping that person, they probably need, if they need help, It might be best to cross their arms if they can't pull, right? Across their chest, cross the leg, one leg over the other, the way that they're going, or pick the knee up and push off with that knee if they can do that. And we're always going to try to just gently raise the roll the person. Make sure once they're over, they're not all twisted. So alignment, nose over toe over navel, even if they're laying on their side. And so just so you know, side rails are considered restraints if you're in a place that has side rails. So we may need to lower them. Now some they're making beds with little side rails that are more like to push and pull for the client. But just keep that in mind. Okay. I love using draw sheets. And there's a picture in their book, and I should have put a picture here, but I don't have one. But it helped. You need two people usually, but not always. And you're actually using it like a hammock in between. The person is, if this was the person, and I'd have a sheet on either side, so the sheet is on one side, one person would be here and one would be here. Anyway, I'll show you pictures and we're going to do that. There's a video. But remember, two people working together along with the client. Hey, on the count of 3, we're going to move you. 1, 2, 3, move. Okay, log rolling. So let me highlight some things and then I'll show you in the book. It takes at least 2 people, sometimes 3 if the person is big. And it's used for spinal cord injuries, spine, right? And we don't want any twisting of the spine. So while someone's laying in bed, we use a draw sheet or a pull sheet underneath, but we make sure that the torso is this part of the body, and the hips and the legs all are moved as one at the same time with nose over navel as we're moving them. Cross the patient's arms is always a good way, but in this case we're going to put a pillow between the legs, the client's legs, and we'll keep one under the head, making sure when they turn they'll still be on it. And caregivers, if there's 2 or 3 of you, at least some hands should be on the shoulder and the hip. And in this case we're usually rolling the person towards us, okay? And make sure their back is aligned. So that's what log rolling is. You're going to keep the person straight like a log. Okay, transferring. This is when we're moving a patient from one place to the other. So it could be from the bed to the wheelchair, from a wheelchair to the chair. And we're going to use a pivot transfer. If the person could barely, if they can't really walk, but they could put some weight down. So pivot would be they're taking little steps, and I know you can't see my feet, but little steps where they're keeping their body in alignment and they pivot. Okay. Tiny little baby steps. Always, and we use this especially for people that are paralyzed on one side. If a person if they're hemiplegic, paralyzed on one side, or just weakness on one side or injury on one side, keep what I say in mind. First, always explain the procedure, and you might even demonstrate it, right? We're going to move you from here to here. This is what I want you to do. Make sure you're keeping the transfer person close to you. Lock the wheels on the beds and on the wheelchairs. Lower the bed to, it's not always the lowest position, so I should have changed that, to a good position. The person's feet have to be flat. The client's feet have to be flat on the floor. However, when we ask them to scoot forward, we may be able to even keep the bed up a little higher with keeping their feet flat on the floor. It'll be easier to get them up. You know, a 6-foot person is going to need the bed a little higher than the 4'10" person. Okay, always have non-slip shoes on. Put the chair at the patient, so the wheelchair usually at their strong side, because they're going to grab for it. So my strong side is my right side. and have them grab for the end of the chair or that type of thing. And always, if we're using wheelchairs, footrests are off. We're always going to use, and there's videos of this, but our hands underneath the gait belts on both sides. I, as the healthcare worker, am going to lift with my legs and not my back. And I'm going to have that patient lean towards their strong side, okay? And I'm going to stay more usually on their weak side. Okay, so we'll slowly turn the patient, and then once the patient it feels the chair, they're going to sit with their back of their knees. If they could feel the chair on the back of their knees, that's the guide to say, okay, it's time to feel for the arm rails, and I'll sit down. Okay, and there's videos of that. So transferring or helping someone ambulate, we have names, and some are active assist, and the patient moves with minimal help, or it could be, we could call that just supervision. Then there's a partial assist. It shouldn't say assistive. Partial assist, the patient is able to help, but we're helping them. And then a total assist, a patient is unable to help at all, and you need at least 2 people to transfer. So let me tell you about transferring patients. There's different equipment, and we're going to go more into this when we go into the restorative nurse stuff, but there is restorative nurses. It's someone usually getting out of rehab, and we're working in that area. But there's slide boards, mechanical lifts, gait belts, and Hoyer lifts. So I'm just going to show you pictures of what this is. So this is someone who would need a total assist. It's a Hoyer lift. This green thing is called the sling. It looks like it's crisscrossed between her legs. And we lift the person out of bed and put them into the wheelchair, or vice versa with this. It's on wheels. These things open up at the bottom, and we're going to call it a wide base of support, just like we make our feet a wide base of support when we're helping lift someone. Then there's transfer boards. These are the most common. Let me put myself up here. And they are, this is a wood transfer board. So the person actually, you put that between the bed and the wheelchair, and they kind of move themselves along on it if they're able to sit up. They have to have good upper arm strength. And then there's these glider ones too. I have not used those, but you could sit someone on it and then slide them onto the other side. And then we have Hemi walkers, and a Hemi walker is for someone who is weak on one side but strong on the other. So it's kind of like a better cane, right? Someone who would use a cane, but needs more support than that. And there are other things like walkers and canes. And again, we'll get to that later, but I just want you to know there's other items available. And we're going to follow the procedures at the facility for lifting. And if you're working through an agency, because they use those Hoyer lifts for agencies in the home, just don't use any equipment without thorough training. You know, that is your responsibility to call the agency. Say, I have never used this one before. Someone needs to come out with me. And know your limitations, because you're number one. You don't want to get hurt. And so you might need other people, or it might be something that just can't get done if they're not going to give you assistance.